Good evening and a very warm welcome to all those who have logged this evening to hear this webinar, Plant Parenthood Post-Transplant. Parenthood is a joy, well, for most of us, but we also know that pregnancy can put a lot of demands and challenges on the mother and those around her. What about pregnancy post-transplant? Does that pose additional challenges? Can I become pregnant after receiving a transplant? Is pregnancy safe after transplant? How long should I wait to become pregnant post my transplant? These are some very real concerns of many transplant patients. These are also concerns that transplant professionals have to constantly address. At the same time, we've also heard heartening stories of recipients becoming parents. So should pregnancy post-transplant bring joy or fear? This is what the subject of discussion is this evening. MOHAN Foundation is delighted to partner with the Transplant Pregnancy Registry International, also known as the TPRI, an international organization specializing in studying pregnancy after solid organ transplantation. The TPRI is an ongoing research study focused on the effects of pregnancy on transplant recipients and the effects of immunosuppressive medications on fertility and pregnancy outcomes. A unique feature of this study is the long-term follow-up of the participants. The TPRI provides information to transplant recipients contemplating post-transplant parenthood and to the healthcare providers who care for them. They showcase data that help recipients and their healthcare team make informed decisions about their parenthood choices. TPRI now has data of recipients from over 20 countries, encompassing more than 2,800 recipients who have reported over 5,000 pregnancy outcomes. They also collect outcomes for fathered pregnancy. TPRI is the longest running voluntary pregnancy registry in the world. There is no Indian data on TPRI yet, and MOHAN Foundation would like to work with all you transplant professionals to showcase our very own successes with parenthood post-transplants. I'm very, very happy to have with us today Ms. Lisa A. Coscia, Senior Registry Research Coordinator at the TPRI, who will talk to us about what TPRI is, what does it do, what is the data they have collected, and what does it really say. Very quickly, Lisa received her nursing degree from the University of Michigan and is a certified transplant coordinator. Lisa has spent her career in the transplant field, holding position as a transplant unit nurse at Hahnemann University Hospital and as a kidney pancreas transplant coordinator at Thomas Jefferson University Hospital. For the past 19 years, she has been a research coordinator with the TPRI, so we really do have an authority on the subject. Also joining are Ms. Kannika Jain and Mr. Vasu Sandur, as they very graciously agree to share their experiences and joys of becoming parents post their transplants. So over to you, Lisa.
Thank you very much, Pavali, and thank you so much for inviting me here today to give this talk and present on something that I'm passionate about, pregnancy after transplantation. So the first thing I'm going to do is show a short video highlighting patients who've sent pictures to us and showing successes of pregnancy after transplantation.
Nice.
So I always like to start out with the first known transplant pregnancy, which actually occurred in 1958. And this was in an identical twin recipient and donor pair that Dr. Joseph Murray transplanted back in 1956. So you can see that from the start of transplant, parenthood was a choice that people wanted to know about and learn about. And interestingly enough, the recipient went on to have 2 children, and the donor went on to have 4 children as well. As you can see here in this picture, that's a little bit older, but these are the 4 children that the donor had, and these are the 2 children that the recipient had. And fortunately, they both were doing well up until about 8 years ago, when the recipient died due to complications of dementia, but maintained adequate transplant function through that whole time. So as Pallavalli said, the Transplant Pregnancy Registry International is a voluntary pregnancy registry that has been collecting pregnancy information for over 30 years. It started in January of 1991 to study outcomes in pregnancies in North America. And then we moved to Gift of Life Institute. And in October of 2016, our name was changed to TPRI, and now we include pregnancy outcomes worldwide. We use a very simple multi-pronged IRB approved method for our data collection. We have an informed consent. For patients in North America, there's a telephone interview that we conduct with the participants. And we also, for international participants, use an online questionnaire, because it's not so easy to collect information from all over the world calling people yet. We are also, our questionnaires are all in English at this time. And we do perform long-term follow-up interviews to monitor recipient and offspring health long-term. And we have patients that have been in the registry since 1991 that we're still following. So I love this map because it shows all the different places that we've collected pregnancy outcomes from. As you can see, the majority are from North America. However, we're starting to accrue more throughout the world. And as said, we haven't been able to collect any from India yet, and really Asia in general, more from Oceania right now. But we're really hoping to be more inclusive over the years and gather more information from all around the world. So what I want you to notice is a few things in this table. So these are the total number of female recipients who participated. And what you'll notice here is that the number of outcomes is greater than the number of pregnancies, because patients do have multiple births. So we have successful twins and triplets reported to the registry. But what you'll also notice is the number of pregnancies is greater than the number of recipients, because patients do have more than one pregnancy after transplant as well. And as you can see, we have almost all different types of combinations of outcomes. The majority are in kidney recipients, which we know that's the most commonly transplanted organ. But you can see we're starting to accrue more in heart and lung, and especially liver recipients too, because we have many recipients in the registry who had their transplant as children and have maintained good graft function for years post-transplant, and now are going on to have children. And as stated, we do collect information on male recipients too. Since it's a voluntary registry, that means no one mandates that we collect this information. We don't have as many men. We know that there's many, many more pregnancies out there, but it's a little bit harder to have men participate in a pregnancy registry. So, but as you'll see, outcomes for men are very different from women. So overall, what do we recommend for patients when they're contemplating pregnancy? So this is from a consensus conference that the American Society of Transplantation held many years ago, but it was based on a case report in 1976 by an obstetrician, John Davison, and these were just kind of modernized and really have stand the test of time. They've really been similar over the years for patients. So really, when you think about it, that first year of post-transplant is when patients are at most risk for infections, rejection, and transplant complications. So really you want the patient to wait at least 1 year after their transplant. Some centers recommend 1 to 2 years. It just depends, since every patient is unique. I think you can kind of assess it as for each patient. And we also know that we tend to use more immunosuppression in that first year. So you know that the immunosuppression after 1 year is going to be less than it is during that first year. And as I mentioned, it allows for a lower risk of infectious complications and allows time for stable graft function. And really, it's recommended that the patient have no rejection in the last year prior to pregnancy, no hypertension or well-controlled hypertension, and no or minimal proteinuria. These were formulated mostly for kidney recipients, but I definitely believe these can be used for all different types of organ recipients as well, because you want a liver recipient to have stable kidney function as well after their transplant. And this is one of my favorite slides because it's very simple. And really, over the years, we found that the calcineurin inhibitors, cyclosporin and tacrolimus, and prednisone and azathioprine are generally considered safe to take during pregnancy. We know that mycophenolate and mofetil and mycophenolic acid, I'll be referring to them as MPA from now on, are contraindicated during pregnancy. And we really don't have enough information about belatacept, sirolimus, or everolimus. However, the data have not shown any problems as yet, but we have very few outcomes with these. So what is the contraindication based on for MPA? So this was an early study that we did comparing our historic information with no MPA use to those pregnancies exposed to MPA. And of 152 of the conceptions, only half were live births, which is much less than we usually see in the registry. We usually see more like 75% live births, which you'll see in a minute in some overall tables. And over half of these ended in miscarriage, stillbirth, or termination. Additionally, 14 of the live births had birth defects reported. And what it was is there was a specific pattern of the malformations. And this is much higher than the incidence we saw without MPA as well. And as you can see, when we looked in the literature, it was this specific phenotype of MPA exposure. And what's also interesting is these birth defects happened in patients who were non-transplant recipients being treated for lupus nephritis and just on MPA and maybe prednisone. So we saw this in the literature and in our database as well. And it was this specific pattern. It was a microtia, which is an external auditory canal defect or misshapen ear, some cardiac anomalies, and facial anomalies as well. So pregnancies with exposures to MPA are associated with a higher incidence of miscarriages and birth defects, including a specific pattern of birth defects in the offspring. So what do we have overall? So we did say we're a resource, and we've helped formulate brochures, and we also write an annual report every year with our overall outcomes. And that's where the information that I'll be presenting today has come from. So it's something that we're happy to provide to recipients and healthcare providers. And anyone who emails me or contacts me, I'm more than happy to send this information to. So here's some of our data and tables. So as you see, the most pregnancies and recipients we have are in kidney recipients. And originally, we only collected retrospective data. So any patient who'd had a pregnancy. Now we can also enroll patients while they're pregnant as well. So what we do is we have pregnancies from as far back as 1967, so 50 years of some pregnancies in kidney recipients, liver from 1985, and kidney pancreas from about 1989. And you can see the age at first transplant is a little bit lower. So some of these patients are having their transplants as young children and might have years of immunosuppressive exposure prior to having their pregnancy. Additionally, most of these patients are waiting even longer than the recommended 1 year. So the mean transplant to conception interval in kidney recipients is about 5.5 years, and in liver, 8.5. And like I mentioned, many of these liver recipients were transplanted as young children, maybe for biliary atresia or other congenital anomalies of the liver, and have gone on to have children much later in life. I think I'm particularly happy with this number right here, even though I'd like to see this as 0 for unplanned pregnancies, because my goal is that every patient should know that they can become pregnant. And if they choose not to become pregnant, be on contraception that's reliable and safe for them. And really, all of these pregnancies should be planned in conjunction with the healthcare team, because we see very high rates of drug-treated hypertension in our kidney recipients, not as much in liver, but still higher in the kidney pancreas group as well. We do see diabetes, which is higher than the general population, but I think overall for transplant recipients is not that high. And this is diabetes requiring insulin therapy. And we do see a much higher rate of preeclampsia in our kidney and kidney pancreas recipients. It's still high in liver because in the US general population, it's only reported in about 3 to 8% of pregnancies, preeclampsia. So it really is a concern for our recipients. And I think fortunately, we don't see a lot of rejection in patients during pregnancy. And many of these are reported as maybe chronic rejection as well. So I also believe that good, stable transplant function prior to pregnancy is a key for a positive pregnancy outcome also. And we do see some graft losses within 2 years of pregnancy, but it's not always necessarily directly related to the pregnancy. And there are some studies out there that have compared patients who've had a pregnancy to patients who didn't, and their overall survival rates were comparable with no statistical differences over time. And what do the babies look like? So as I said, about 75% live birth rate, which is, I think, fairly good for our population. But we do see that the babies are born about 4 weeks early for kidney recipients. They're born a little bit closer to term for liver and a little bit smaller for kidney pancreas. And we do see quite a bit of the late term, preterm births between 32 and 37 weeks, not as many very preterm. And our birth weights in the United States, this is about 5.5 pounds, this 2,500 grams. So this is a little bit lower than we see in the United States population. So we do see some low birth weight. Interestingly, too, despite saying that it's not a requirement that a patient has a cesarean section, we do see a very high rate of cesarean section births for our transplant recipients. So it's something that's very common, even though they say cesarean section should be reserved for obstetric reasons only. And overall, our birth defect rates are very comparable to that of the general population, which is about 3 to 5%. And we have a very small number of neonatal deaths as well. So with that, I would like to bring to the stage Kannika Jain, who's going to tell
Lisa,
us. Yes.
We just have a few doctors,
Oh.
nephrologists from the Mumbai Nephrology Group. I would like to welcome them, Dr. Mehta, Dr. Sisat, Dr. Hegde, and I hope you will stay back for the discussion post the recipients sharing. Welcome. Thank you so much for taking the time.
Thank you.
Yeah. Over to you, Lisa. Sorry.
Okay, no problem. Is Kannika there so she can share with us how she did? I know she was on earlier.
Kannika?
Yes,
Yeah.
yes. Hi,
Oh,
good
there you are.
evening. Hi, Lisa. Thank you, Lisa. Thank you, Pallavi,
Thanks
for inviting me. I'm honored. It's always beautiful to share my journey. Thank you so much for inviting me. In fact, Lisa, a lot of things that you spoke about in your presentation, I have experienced that. So my kidney transplant was done about 8 years ago. And I was given a go ahead by my nephrologist roughly 4 years afterwards to have a child. My husband and me, we'd been married a couple of years at the time. I was 33 at the time of transplant, and we were very, very desperate rather to have a child. So our nephrologist was of the view that, your tacrolimus and your other levels, creatinine, everything needs to be in balance before you can plan a baby. And it took me about 4 years to reach that level. And of course, we were informed well in time that some of the medicines will need to be altered
Yeah.
before the conception. So mycophenolate had to be substituted with azathioprine. So, and one thing very interesting I remember my nephrologist telling me is that I'd like you to be very realistic, because there are times that couples try to get pregnant for months, and it can take a while. So you'll need to keep your patience, you'll need to keep your positivity in place. So, but I'm very fortunate. I'm very, very blessed.
Kanika, I'm just, Jain, we would like to have full screen while Kanika is talking, while the sharing is happening. Can we please? Yeah, thank you. So sorry. I'm so sorry. Yeah.
No worries, no worries. I'm getting attention. I'm happy. So my nephrologist, one sweetheart, he is like, you need to have patience, you need to have positivity. And there are times when couples try for 6 months, 8 months, to get pregnant, and it can take a while. And since the medicines are altered, the kidney functioning needs to be very closely monitored, while you are in that phase of conception, when you're trying to conceive. So he changed my medicines, and I conceived. I'm very fortunate, we conceived within my first menstrual cycle. So he was also very happy, shocked, surprised. Oh, yes. He said, you're my first patient where I'm counting the number of days since I changed the medicine, instead of the months. So it was very beautiful. It was very beautiful. Also, one of the important things that we did was, my husband and we needed a gynecologist who had at least some sort of experience of dealing with pregnancies for kidney transplant recipients. And in India, currently, from whatever little knowledge that I have, it's rare, So again, we found a very awesome lady. She had a lot of experience with dealing with patients like that. And my nephrologist and my gynecologist, they worked in tandem for during the pregnancy, and my labs, my blood tests, urine tests were very closely monitored. Of course, I'm fortunate in another aspect is that I did not experience any backache or any swollen feet during my pregnancy, which is perhaps common for any lady, irrespective whether they are organ recipients or not. And I attribute that to my yoga, because for years before that, I'd been doing yoga. So my spine was very strong. Both my doctors, they operated cautiously. They wanted to proceed proceed with caution. So they stopped my yoga. I hated both of them for that. But oh yes, because I am a yoga and a meditation person, for years now. And that's my strength, my inner strength comes from that, my yoga and meditation. So I walked a lot. And that helped me a lot. Not a single day did I experience any sort of back pain or swollen feet. Oh, yes, it's been a very beautiful journey. It's only towards the end, somewhere around 32, 33 weeks, the UPCR, the urine protein creatinine ratio, which was regularly monitored, indicated that now the time has come that, the delivery needs to take place. Kidney is getting impacted and we really need to speed up. So a lot of options were put forth, and they said that, after birth, your child may have to stay in NICU, newborn ICU. I said, that's not happening. So what's the other options? He said that during pregnancy, we can give you a whole bunch of injections, which will help in lung development of your baby, before birth. And I went through some very painful and burning injections in the last 2-3 weeks.
Wow.
But the good part is my son Veer, he's 3 years old now, and he did not have to go through anything, no pain. He was born effortlessly. He was a happy, healthy child. NICU was really far away from his life. And it's been very beautiful, very easy for me. One or two things which were of concern to both of us, my husband and me, was that whether I will be able to breastfeed my child after birth. So since I was on, hopped on a whole bunch of immunosuppressants, steroids, and other medicines, and blood pressure medicine, and all of that, we reached out to a couple of experts in the medical fraternity before conception and during pregnancy. So they said that's not a problem, because even while during pregnancy, in any case, your child is getting that medicine through your bloodstream. So it's not going to affect that. Of course, you will continue to stay on azathioprine and cannot move back to mycophenolate till the time you want to feed, because as Lisa shared, that can affect the fetus, that can affect the baby. So again, I was able to breastfeed my son for 6 months. And after that, my medicines were changed back. One of the very interesting things that happened was that the moment I was moved back to mycophenolate, I had acute diarrhea. I developed a lot of bone and muscle pain for about a year and a half. And unfortunately, since these cases are rare, not much of practical experience information is available. Yes, that's right. So that information is not available. My gynae, I was in gynae, I was touching with my gynae even afterwards. For almost a year, I was in touch with her. They had a tough time figuring out what's happening because no data, no practical experience information was available. So, so much of hormones had changed during pregnancy that they affected my bone and muscles. And that in any case is a bone loss and muscle pain and all is in any case a side effect of one of the medicines that we take. I think that side effect kind of kicked in after delivery. However, with some supplements like magnesium and other things, a lot of body massage, a lot of yoga, especially yoga, a lot of yoga and meditation helped me to get back. Milk, of course, I could not drink milk afterwards, because it really changed everything within my body. So milk gave me diarrhea. So now it's been, more than 2 years, and I love milk actually. That was
Kannika, one of the viewers wants to know who your nephrologist was.
Sure, I'm not. I don't mind sharing. I'm not sure if he would. So with due respect to him and a lot of gratitude to my nephrologist, his name is Dr. Saurabh Pokhriyal. He's director nephrology currently in Manipal Hospital in Dwarka, New Delhi, India. Gem of a person, awesome person, not only medically, not only a medical expert. He's been my agony uncle also last 8 years. Oh yes, I complained to him about my hair loss and my husband also. So as all my fellow organ transplant recipients know, a lot of mood swings happen, a lot of hormonal changes happen, and extreme hair loss happens. I keep complaining to him. I said, you don't love me. You don't care about my hair. I've lost everything. So he's my agony uncle as well. But jokes apart, medically, he's an awesome person. He's a medical expert. So where was I? I'm sorry, I forgot.
That's right. I was just going to ask you, so how many weeks were you when you did deliver your son?
Okay, so my injection started around 33, 34 weeks, and my son was born at 37 weeks. It was around yes, absolutely. So he was born about 2 to 3 weeks sooner than the due date. And he was fine. And one very important thing about my life here that I want to share with all of you, all my fellow organ transplant recipients, who are planning to have a child, or even if, those who've already had one. For me, for 16 years since my kidney failure, transplant, and now post-childbirth, my developing on my inner strength, my mental health, my emotional health, my spiritual health, is largely responsible for where I am today. It has changed. I have dedicatedly, I have worked on that. I have learned and I have practiced to balance my body, my mind, and my spirit. So when my mind and spirit has been in balance, it has helped my body. And that's how, my transplant
that really
happened.
is the key, Kannika.
Yes, absolutely.
Yeah.
And I think having the planned pregnancy with all of your laboratory values being in check and having your medicines, I mean, you had definitely, I think, what I would call the ideal pregnancy.
Fantastic.
Oh yes, I consider myself blessed. In fact, if I may take a minute or more of your time here, Professionally, I'm a psychologist. So a lot of my clients are these organ transplant recipients. A lot of them are women who plan to, who are planning to have a child now after transplant. And a large part of my conversation and counseling and therapy with them is around addressing their fear. So many times, most of the time, recipients are scared. Women recipients are scared. Can I have a child? Will I be able to conceive? How easy or difficult will my pregnancy be? Will my child be okay? I'm hooked up on so many immunosuppressants. Will I have a normal baby? How will my baby be? Will my baby have a normal life afterwards, free from defects or deformities or abnormalities and everything? So, of course, medically, physically, tons of experts are there. And this one thing that I want to share with them is please work on your mental and emotional strength, because once you're able to let go of that fear, everything becomes easy. And I say that with a lot of confidence because I have lived that. I have gone through that.
That's fantastic, Kannika.
Yeah.
That's real. Would any of our nephrologists like to come in at this point? Any comments? Anything? Dr. Mehta, Dr. Sirsa, Dr. Hegde, anything that you would like to, before Lisa goes back to the rest of her presentation? Okay. Dr. Sirsat, tell me. Yeah.
I think Kanika had a very nice course for her pregnancy, uneventful, and it's the ideal way, actually.
That's true.
Which does not happen for most patients. They have a rocky time sometimes, So, good that she had such a, and I think it's that attitude which helped her, because she's very positive.
Thank you.
That's, I think, largely the key. Dr. Mehta?
Yeah, I too agree with what Rasika is saying. But I have more experience of males recipients fathering kids. And they have obviously gone through well because they do not have to have
pregnancy.
Yes, so
we'll have Vasu share
yes,
subsequently.
So that's the main problem.
Thank you so much. And thank you so much for taking the time to be with us here today. Lisa, you want to go back to your presentation? Yeah.
So in contrast to the outcomes in female recipients, we really almost see no difference for male recipients. It's much different in the case for them. As you can see here, in the registry, like a 90% live birth rate, 39 weeks at mean gestational age, mean birth weights similar to the general population as well, and the same with no birth defects. And what I wanted to really share is that we saw no problems with mycophenolate exposure when men are taking it. So because we had historic data to compare to, we had pregnancies with MPA exposure in men and those without, and there were no statistical differences in any of the outcomes. So this is much different. And I've actually had this question asked of me many times: should I take a male off of MPA prior to conception? And I say, absolutely not. The stable graft function is very important for them. And if you don't have to change their medications, please don't. And there was a group in Norway that looked at all the Norwegian outcomes in men as well, and they did not find any problems with the mycophenolate also. So I think that's very good to know. Overall, the outcomes of pregnancies fathered by transplant recipients, they appear similar to the general population. And currently, our data does not support the avoidance of MPA for male recipients who are considering parenthood. And with that, I would like to introduce Vasu Saunder, who's had his transplant for a very long time, almost as longer than the registry. And he's going to tell us a little bit about his story.
Hello. Hi.
Hello.
Hi, everyone. Thank you for giving me this opportunity to introduce myself. I'll give a small brief about me. I'm about 26 years or 27 years ago. I was diagnosed as my kidneys were failed, and my mother has given me one of her kidneys about 28, 29 years back. So 92, I underwent my transplant. In 96, I got married. During that time, I was preparing for World Transplant Games in Sydney. I am one of the first Indian to participate in the World Transplant Games in 97 in Sydney and 99 in Hungary. After that, in 96, I got married, and 97, I got a female child. First female child in 2000, I got a male child. Both are doing well. There are no issues. And I wanted to tell about transplant recipients. First 6 months to 1 year, there are generally rejection episodes takes place. That's why I advise them not to go for this parenthood during this first 1 year also. And also you will be on most of the time you will be on higher immunosuppressant drugs. That's why I suggest not to go for that. After that, you can have whatever you choose for that.
Vasu, was it a planned discussion with your nephrologist, or was there any discussion?
I consulted my nephrologist, Dr. Siddharaj. He is very senior most nephrologist in Karnataka. Of course, he is no more now. I took suggestion from him. He asked me to go ahead with marriage. So I got married in 96. She is here, my wife,
Hi.
Padma.
Hi, Padma.
Hello.
And she is my daughter. She
Hi.
has done
How lovely.
she has done her engineering, and he is my son.
Hi.
Both are doing well. Yeah, now I wanted to tell the recipients that you have willpower and also self-confidence, so that you will be normally you can go ahead with everything, whatever you plan. That is what I wanted to tell.
Fantastic. So one of the questions was, how are your children doing? Well,
both are doing well.
That's fantastic. You also said, what would you suggest to a young man who's just had transplant? So that's good. That's fantastic. Yeah. That was great sharing. Interesting, because Vasu had his transplant so many years ago, and there was
about 30 years
very little information and very little discussion on such issues so actively as vis-a-vis Kannika. So thank you so much for sharing.
And congratulations.
Padma. So what were your concerns, Padma, around parenthood when you were marrying Vasu?
I'm well. What do you feel?
How do you feel that one?
What you felt when you got?
Sorry, one more time, please.
So I wanted to know, as a person who was marrying somebody with a transplant. So many couples have, one spouse undergoes a transplant post-marriage, but I know in your case you had already had a transplant, and then she married you. So I want to know what were her concerns and what are her.
When I got this marriage proposal, I took her to my Dr. Sundar. He is one of the senior most nephrologists in Karnataka. He advised her to go for marriage, and she can have normal children and everything. So she got married.
Fantastic. That's really nice to hear. Thank you.
Two wonderful stories and success stories, and how the donors, and life goes on, and it continues even after transplant, which is another wonderful part of transplant.
Dr. Hegde, you had unmuted yourself earlier, and I would you like to say something at this point? Do you have a comment to make?
No, she had a wonderful time, and there was no complications. As Shirsak Madam also told, everybody is not the same.
That's true.
Right.
Yeah, we also had both experience, which we had even at near term. We had an IUD, and we had to consider a lot because she went into depression. So other people had a good time. So, as far as the parenthood, we had good results. There was no problem. So it is both mixed experience,
Sure.
especially in a woman.
Sure.
Mhm.
Thank you. Thank you,
Yeah,
Dr.
Thank you.
and we definitely see, some people, get preeclampsia very early and have to deliver at 27 or 28 weeks. It's very different for each patient, and that's what I always like to tell people when I talk to them, is that every pregnancy is unique, and that's why we feel like the more outcomes we have in the registry, the better it will be to be able to kind of get more definitive guidelines out there for patients.
Yeah. So,
I just have a little bit of summary slides, and then I
Sure.
think we can go back into discussion if that's okay.
sure.
So, so recipients of childbearing age should be counseled regarding the feasibility and timing of pregnancy after transplant. We know that pregnancy and fertility can return very soon after transplant, and we have seen patients get pregnant within that first year after transplant. So it's very important that they use effective contraception in that first year as well. And pregnancy and maternal outcomes definitely vary based on multiple factors, especially on the type of organ transplanted. We actually do have outcomes in heart and lung recipients, and we do see some more rejection in those patients compared to our kidney and liver during pregnancy. And these pregnancies are high risk and with increased incidences of hypertension, preeclampsia, and prematurity. And as we saw with Kannika, that this multidisciplinary approach with the obstetrician, the nephrologist, neonatologists, endocrinologists, and working all together can really help with a successful outcome. And we're here to continue to collect and give out our information. It's really important that we are able to give this information so people can make an informed decision about their parenthood choices after transplant. And we write, like I said, an annual report every year. I'm happy to send this to anyone who would like it. And this is our contact information. If you'd like to contact me at any time, I'm happy to talk to anyone about these results. And we have some specific studies too. We've looked at GFR prior to pregnancy, estimated GFR. We've looked at specific patient populations like those with lupus and their outcomes and to see how they are. And we've also done, which I think is an interesting study, is looking at patients that have had more than one pregnancy after their transplant. So if they want to have that second baby, what do the outcomes look like for those patients as well? So now let's open the floor for some discussion.
Yeah.
And I'm happy
If
to
you can stop your screen sharing, we have some questions, Lisa. So someone wants to know, how soon after transplant can one have a baby?
We've had people report, I think, within a few months after transplant. Fertility can really return soon, especially with a successful transplant. And we even know nowadays, with dialysis being so good and with epogen and the hemoglobin being up, patients do get pregnant on dialysis too. So their fertility can return very quickly after transplant. So it's really important that patients are aware that they can get pregnant if they're sexually active, and that they're on contraception that's safe and effective after transplant.
Someone wants to know, are there recipients who are at a higher risk for complications during pregnancy?
Definitely. So if someone's had a recent rejection, or if their transplant is not stable, even if they have some diagnosed chronic rejection, if their creatinine is above 1.5, we definitely see more prematurity, more graft loss. So there are patients that probably should be advised not to have a pregnancy, or that they might lose their transplant if they become pregnant. It's just like someone who has kidney disease without a transplant. Pregnancy is not necessarily going to help your kidney function if you have some dysfunction prior to pregnancy. And also, we know that active CMV can be harmful to the baby and other infectious diseases. Knock on wood, so far we haven't had anyone who's had reported COVID during pregnancy after transplant right now, since that's something very prominent and happening all over the world. But as of this time, no one's reported any COVID during pregnancy.
Okay. I just wanted to ask the doctors here if they know of any patients on dialysis in India who've had pregnancies. For our viewers, anybody, any of the doctors here?
Yeah, thank you. We had one of my colleague who's in Baroda. He's one of our patient on dialysis had a successful pregnancy, but the weight was slightly lower. It was around 1.9 to 2 kilos, but she had a successful pregnancy, which I know of. He's my colleague. So
Okay. Okay.
I know.
Yeah, I too, in my case also, we had one who's creating, she was on dialysis, but we had definitely advised her against pregnancy because she had uncontrolled hypertension. But yes, she went through a successful pregnancy, though she had all the problems of, low birth weight, but it was a successful pregnancy. But otherwise, the experience is not so good. Even anybody with not on dialysis, they usually worsen very rapidly on during pregnancy, worsening her kidney functions.
yeah, this lady was dialyzed 5 times a week after
That was
confirming.
going to be
Yeah.
my next question is if you dialyzed or more, because that's what they say needs to happen.
Dr. Kulkarni has joined us. Dr. Kulkarni, do you want to make any comment while you're here?
No, thank you.
So this is a question for Kannika. She may choose not to answer it, but are you thinking of a second baby?
No, I will not, because I'm almost 42 now, and taking care of a toddler at this age, is very difficult for me. I really don't have that kind of energy to match my child. And it has nothing to do with my kidney condition or any such thing, but it's primarily because I really don't have the energy to handle another baby.
Okay.
I just want to ask Kannika.
Anji.
You had UPCR, which was which increased towards pregnancy, right?
Yes. So towards the end of pregnancy,
how fast it settled down?
You're saying after delivery, how fast it settled down?
Yes.
I'm sorry, Dr. Kalpana, I'm not, I don't really recall that much, but yes, it was pretty normal actually. It took a little while, but it was normal. I really, honestly, I don't remember that. So yeah, I'm so sorry.
That's okay. Thank you so much. This is again question for the doctors here. Do you think there is an undue pressure on lady kidney recipients to have babies? And how do you handle that?
Absolutely. Absolutely. And we have to call the family members and counsel them, because sometimes they put undue pressure, and that may be detrimental for the health of the patient. So, I mean, there is always a pressure on the female recipient as compared to a male. Male, they get married also easily, whereas I have only 3 or 4 female recipients who got married after a transplant.
Post-transplant, Lisa, what's your experience on this?
I feel like it's a little bit different in the United States, where patients just want to get pregnant. I just see so many that talk about wanting to get pregnant. I don't think there's as much pressure for the Western, recipients for getting pregnant. It's more of a choice and more wanting.
More autonomous kind of.
Yes. Mm-hmm.
Yeah. Okay, someone wants to know, is there any difference in outcomes in living donor versus deceased donation?
You know what, we actually did a study on that a few years ago, and really we didn't see a huge difference. And actually the deceased donors had a little bit better creatinine pre-pregnancy, where I think that was more of a selection bias, where, probably they were counseled, those with really good transplant function were counseled that they could have a pregnancy. And like I said, in postpartum, the creatinine was slightly higher in the living donors, but overall, the children outcomes, pregnancy outcomes were all the same. There were no statistical differences. So that's a great question, but we really haven't seen a difference in our study, those that have reported to us.
Dr. Lisa.
Yeah, sorry. Yeah, Dr. Mehta.
Yes.
Dr. Mehta? Are you asking a question? Okay, I don't understand this question very well, but is it why?
Can you hear me now?
Yeah, Dr. Mehta,
Yes.
we can hear you. Yeah.
Yeah. Just one thing. See, usually what I've seen in the over last few years of transplant, when we are changing to tacrolimus and MMN, CMV infection has really gone very high. And as Dr. Lisa put it, CMV infection is an important factor during pregnancy post-transplant. And many of the transplant in United States are deceased donor with a higher definitely immunosuppression than live-related transplant in India. So how common was this CMV infections and the effect on it, Dr. Lisa?
You know what? It's actually interesting because we haven't seen a lot of CMV infection during pregnancy. So I think part of the problem is if someone's had a lot of problems with CMV, maybe they've not even become pregnant. And that's where, since we're a voluntary registry, it's kind of hard to know who doesn't become pregnant, because I know of patients who've tried to switch their MPA to azathioprine, but have a rejection and never have a pregnancy. So we really don't even know what our true N is of patients trying. But it's interesting because I just listened to a webinar about CMV and pregnancy last weekend, and they're doing some really interesting things of treating patients who have CMV. These were non-transplant patients in just the general population, but just giving high doses of IVIG and anciclovir during pregnancy in order to prevent that transmission of CMV in the babies. So I think there is some things that they can do now with CMV during pregnancy, but it can have very detrimental effects on the fetus. So it's something that should be looked at prior to a planned pregnancy as well. But I think fortunately, we haven't seen an increase in reports of CMV with the registry.
Okay, so one of the listeners wants to know, why is there a general risk perception about having babies in India? I guess this goes to our Indian doctors. And how come there are not too many positive cases in India when it comes to pregnancy post? And I think this other question is related. How do we promote parenthood in recipients in India? I think it'll have to be one of the Indian doctors. I don't think Lisa can answer.
Yeah, I can't answer that one. Sorry.
I guess to have data out there like the one that you have is very important, because data speaks for itself, and having people like Kannika and Vasu sharing it in the manner that they have is good.
Hello.
Vasu, you wanted to say something? Yeah.
Hello.
Yeah, sure. Dr. Hudson.
Yeah. But basically the problem is pressures from the mother's side or mother-in-law's side. But what we see is if there is any good over 1 year or 1.5 years, if there is no rejection in the first year, and if they want, we change from MMF to azathioprine, and if they are tolerated for 3 months and we went ahead, we have almost around 15-20 in the last 4 to 5 years. We had pregnancies. Again, one of them may be problematic. One of the last 2 pregnancies among them who had problems, otherwise they had successful. One of them, 2 patients, they underwent an induction because they were not getting pregnancy, but again they could not have any pregnancy because of the IVF, so then they adopted a child. So another 15 pregnancies in the last 5 years, which is reasonably good. Among them, 1 or 2 had problems.
That's actually really good results, it sounds like. And I know sometimes if a doctor has a case that's really not a good outcome, and for baby and mom, that can really kind of not give a good history for positive pregnancy outcomes. So it can be very difficult, and it's something that you really have to think about with saying they've gotten this very good, wonderful gift of a transplant, and how best can they serve it. And like I said, sometimes pregnancy is not recommended for everybody. And also sometimes you have to look at the disease process that the patient had to begin with, of why they were transplanted. Is it something that they could pass on to the children? Do they maybe need to have genetic testing done? prior to having a baby as well.
Yeah. Thanks, Lisa. So Radhika Sharma wants to know, what are the chances for safe pregnancy in women recipients who had IgA nephropathy? What are the chances of child developing IgA nephropathy post-delivery?
I don't think we've looked at IgA specifically yet in our population, but I definitely have patients who've had IgA and then can sometimes have a recurrence. We know that disease is, very difficult sometimes. And I believe some patients have done genetic testing. And I know in the United States, you can, do IVF and get the fetuses tested beforehand to see if they have the disease or not. But I haven't looked at it specifically in our data yet to answer those specific questions.
Okay. We have one or two questions more before I think we have to wind up.
Pallavi,
Yeah, yes, Vasu.
just I wanted to add one more point.
Sure.
Many of the people having that misconception that post-transplant medication will be having some impact on the babies. In my experience, there are no such impacts on the babies. That is, whatever medicine we take post-transplant care, that medicine effect will not be there on the babies. That is what I experienced. There are a lot of misconception on this.
Thank you, Vasu. I have a question for both Vasu and Kannika. So the whole idea of having this webinar was to explore whether post-transplant recipients who've had children would like to be part of such a registry so that, data from India can be generated and shared with other patients for them to take, recipients to take informed decisions about pregnancy and parenthood. Would you be willing to do this? Would Vasu and Kannika be willing to be part of such a registry?
Yes, absolutely. Absolutely.
Yeah.
Love
Great.
to hear it. Thank
Great.
you.
Yeah, Pallavi,
Yes, Vasu.
I wanted to tell one more thing.
Yeah.
We have an association called Kidney Patients Welfare Association.
Okay.
It is one of its first of its kind in India. We started about 30 years back. We are counseling the patients regularly on this post-transplant and post-transplant, and also about the pregnancy also.
Okay.
We are doing that for a long time.
Fantastic. So we can probably reach out to you as we move forward with the
sure.
Indian data.
Yeah.
That would be a great help. We have just one question, a COVID-related question. So if a transplant recipient was COVID positive, when can they plan to have a baby?
I don't know the answer to that, to be honest with you.
Yeah.
I'm not even sure in the general population what they're recommending. I know being COVID positive while you're pregnant, the outcomes are sometimes not that great, but I'm not sure about how long they're supposed to wait afterwards when they've had active infection. Sorry about that.
That's all.
I'll have to
Thanks.
look that one up.
Yeah, it's too recent to draw these, but so tell us, Lisa, we are excited about this. We are excited about capturing Indian data and sharing positive stories of recipients of like Kannika and Vasu, and even the ones who have complications. We need to have data to help.
Yes, sure.
Yeah, so we will take that forward with you. Anybody has any comment to make? I think I have no. Except compliments on my sari. I have no other questions. So
wonderful.
Yeah.
I really appreciate your time and everybody joining us today. And if anybody has any specific questions, they're free to email me and I can send them our annual report or any other reports that we have.
Thank you so much, Lisa. Thank you, Kannika and Vasu, and thank you all the doctors who joined time so late in the evening to join us. Really appreciate your inputs. Thank you, Teresa, for being there. And good night to all of you.
Thank you.
Great evening, everybody. Thank you.
Thank you.